So now that we've made a diagnosis, thanks to Momen's help, and you've helped us communicate it to the patient, how do we define the next steps as to who is primary resectable, who should take a different approach, and if somebody is resectable, maybe still discuss some alternate options, such as radiation with our patients?
Yeah, so surgeons think about two issues. One is medical operability of the patient, which is really performance status driven, cardiovascular and pulmonary status driven. It's more the fitness of the patient. So medical operability pertains to the patient. And then there's surgical resectability of the tumor and the lymph nodes. And to the surgeon, these are two entirely separate issues. So you could have resectable disease, but be medically inoperable and not make it to surgery. So you need both to be aligned. And I think those issues of who's medically operable and surgically resectable is highly variable depending on the institution and the surgeon. And amongst different surgeons at the same institution, there are different thresholds. So there isn't one good way to pinpoint a fine black and white line of who's medically operable and who's surgically resectable. I think the greatest controversy comes in the invasive T4 patients, the multi-stage N2 patients, and then the pneumonectomy patients, all of which have been included in all of the neoadjuvant or perioperative trials except for Aegean, which at the time of screening were excluded, but if they ultimately need a pneumonectomy, they were allowed to get it. But I think it's important to recognize that those are probably the three subsets of patients that are most controversial.
Great. And I think in this team, maybe I'm the closest to radiation oncologist. So just to stand up for our fantastic, other subspecialty. Certainly in the inoperable patients, we have fantastic modalities now to still achieve a high rate of cure potentially with the use of stereotactic radiosurgery. And of course, radiation-based treatments can be appropriate for kind of multi-station, node-positive patients where maybe the surgical approach is not ultimately the right one. Let's come back to this resectability and multimodal treatment. Nowadays, with neoadjuvant approaches coming into the foreground, it's even more important to stage patients correctly. It's one thing to diagnose, it's one thing to have a sense of the stage, but now we need more accuracy, right? Because if somebody is node positive, it's so important to at least consider whether a neoadjuvant approach would be more helpful. So maybe I can throw this question to Momen. So the mediastinum is now your organ. How do you make sure that we're not missing out on the option of better treatments maybe for occult node positive disease? Do you do an EBUS procedure on each patient who will go for resection? What's the current standard of care?
Yeah, I mean, I think this is such an important topic. We know that even if the mediastinum is negative on CT and on PET scan, that there's about a 10% chance that there might be metastasis in the mediastinum. So really the push has been to try to look at the mediastinum always before resection. So could be done with mediastinoscopy, could be done with endobronchial ultrasound, with bronchoscopy. But yeah, it's routine now when we're trying to diagnose cancer, lung nodule, lung mass. Even if the mediastinum is clean radiographically, we look with endobronchial ultrasound, and any lymph node that's higher than 5 millimeter in size gets sampled. And obviously we do it systematically from the contralateral side to the side of the primary. And so I think we are now seeing that being utilized more and more. And I believe, we've had studies 20 years ago that showed that we did not do well in staging. We relied too much on radiographic studies, PET scan. We know that PET can be false positive or false negative. And I think clearly there's been a push to be more aggressive in sampling the mediastinum. I mean, we have the tools now in endobronchial ultrasound that's not very invasive. And so anytime a patient is getting a diagnostic procedure, they're usually getting a look at their mediastinum to ensure that there's no metastasis.
Fantastic. And I might say that there was a very nice study from Australia just a couple of months ago highlighting that even patients who get primary radiation, maybe that EBUS procedure is still helpful in that case because we're upstaging some and they could receive better treatment than just definitive radiation. So is that becoming routine as well?
Yeah, I mean, again, there's different thresholds for different programs in the country, but I think increasingly we advocate for that. approach if you're going to do SBRT to a stage 1 lung cancer. It would be beneficial to look at the mediastinum. We gotta balance, invasiveness of the procedure. It's still anesthesia and a bronchoscopy versus the likelihood of metastases. So if it's a 1 centimeter very peripheral lung nodule, probably okay to not look at the mediastinum. But the more central the nodule or the primary is, the bigger size, or the presence of hilar lymph node potentially, that all pushes us toward let's look at the mediastinum.